So how during drilling, my drill would have touched this lingual cortical plate. Then I respected it and stopped it. I measured the length. It was
This is good, perfect.
yes. If I would drill it like this,
Yes.
I would have taken a longer interval. So anteriorly, the golden rule is respect the resistance by the drill. So here, when I drill, the drill was touching here. I didn't push violently and perforated here. So this length I selected, it is perfectly fitting. This is 3-2. Okay, it is also correct. Yes. Okay. This is also correct. Now we will see the lingual cortical region.
It is perforated and
Yes, 1 or 2 mm into it. It's correct.
it's not also issue. Not also an issue.
No, not issue. The only thing is bending without cracking. The entire bone is soft. Here also it is. See, 4 implants are straight. These 2 implants are lingual cortical engagement. This is the issue. Now we will bend it. You have to do bending very carefully.
This is also.
Yeah, it is also. See, I kept one finger on the lingual aspect. The drilling was done. This is the distribution. Here also,
Yes.
it is correct.
Correct.
So only success relies on the proper bending without any fracture.
Yes.
See, there was automatic artificial intelligence. It will trace the nerve canal automatically, but it couldn't able to trace the canal because it couldn't able to see because of osteoporosis. Yes. Now we will bend. So bimax protrusion, lip competence is there, proclination is there. Apart from that, gum issues, teeth mobility, these everything is there. So the patient is consciously closing the lips. You can see the lip puckering effect.
Yes.
Mentalis muscle. You can see the proclination. So let's see the intraoral view. Multiple periodontal abscess. You can see the big bulge here. And lower looks good from the outside, but lingually there is a lot of calculus and bone loss. And apart from the big bite and long-standing missing tooth, multiple abscess here. You can see the abscess here also. So, what will be the plan? We are going to do full mouth. Apart from full mouth implant rehabilitation, what is the plan to satisfy the patient needs? Missing tooth is there, periodontal abscess is there, proclination is there. Can we do ortho for this kind of situation? No. So what else we can do?
Full mouth rehabilitation
is the only option. Yes. Even though few teeth are looking good, we are going for full mouth rehabilitation. Okay. See the lingually. Pockets everywhere, big filling here. So, it is a full mouth situation. Okay. In case if the patient is asking, just give me only here. Just give me only here. Okay. What will happen is, if we give only upper, then these tooth and all will become mobile. Future, after 2 years, it will go for full mouth.
Yes.
At the time, giving a good aesthetic result is not possible. Okay. So, better to solve everything at once. So, we will plan for the lower full mouth. So, this is one view. This view is called reformatted view, 3D reformatted view. You can see the knife edge ridge here, recently fallen down premolar here. You can see the lingual bone loss inside the CT molars. And one more factor we can observe here is it's a long face. It's a long face.
Yes.
Okay. So long face patients, they will have this anterior mandible height more. Posterior prosthetic space will be very less.
Yes.
We will have difficulty in giving it.
Yeah.
And for them, the bone also will be very thin. The long face patient. and they will have deep palate. Okay, so these things, they are important in implant planning. So this is the panoramic view. Okay, so what is the plan? Luckily, the nerve is visible. That means the bone is somewhat good. Okay, it comes still here, right? This is canine, this is first premolar, this is second premolar. Maybe this is the loop. Yeah, this may be the loop, this is the metal foramen loop. Maybe here. Mostly it is in the second premolar, this area. But the canal layer is not visible. That means the bone quality may not be good. Okay. So what is our plan? Tentatively we start with the 8. First premolar. This is first premolar, right? This is first premolar. Lateral incisor. Lateral incisor. This is the intraforamina planning. Intraforamina planning is very simple. Distal mandible to here to here only the challenge is there. Back to place. The moment you extract, can you see this interdental bone is like this. This plate also will come along with the extraction.
Yes.
Because this part is it's locked within the root. So in this socket, placing a good implant may not be possible because it will be a big empty socket. So better to place an implant in this interdental bone, right? And we can place one implant in this interdental bone or place a wide basal 5.5 in the premolar. Okay, this is our tentative plan. We will see the cross section now. You will see the metal foramen area. This is exactly the metal foramen area.
Yes.
There is a lot of length available is there, but the buccolingual width is less.
Yes.
Maybe very small diameter implant.
3.5.
Yes. But however, we are going to plan for the first premolar, right?
3.5 by
Yes.
10.
Yes.
Yeah.
10 or 14.
14.
We can clearly observe the loop coming here, right?
Yes.
This is the metal foramen coming loop. So slightly mesial tilt will be fine.
Yes.
Okay, 4 into 14 or 3.4 into 14 something. But still, no, as we already discussed, long face syndrome, the buccolingual width will be very thin. Now we'll plan for 4-2. I just have it done. See the bone shape. Very thin buccolingually, like all along. Sometimes it will be like this, very wide. You have a lot of bone, but here it's very limited. Buccal to root no bone, lingual to root no bone. Only through the apex you have to drill. Okay, so you will be doing alveoloplasty till here, tentatively. So from here to here, you will see. So 3.5 mm will be better, right? We can go till the lower border.
Chaos.
Yes, KOS. KOS are compression screws. This is 3-2. Here it is much worse. This is called hourglass shape, right? It is coming like this, no? There is a constriction here. So what implant to place?
BCS.
Yes, BCS will be ideal because it will engage this spot.
Yes.
Or use a 3.5 smaller diameter compression implant. So depending upon the situation you can use. The main thing is, if you use a BCS like this, it will become loose. That's why some doctors are telling. Initially I am getting good stability, but after some time it becomes loose. That is because you are crossing beyond that. So if you are placing basal, make sure you are staying within this limit, not going here. Okay. If you are using compressed implant, you can go till here. But if you are using basal, so without simplicity, how will we know this? So during drilling, feel it. You will feel resistance here. Suddenly, you will feel the drop. That means there is a cancerous bone here. So plan accordingly. That is the CBCT. Okay. So what is the CBCT alternatives? One is flap elevation. You will see the buccolingual width clearly, right? The second is
drop.
Drop. Either the second cortical perforation or this difference in density, bone marrow. Drop in the drill. So during drilling, feel the sense. Okay. Then what else? Okay.
Pre-op scan. Pre-op scan.
Ele good to almost the 3-2. Is almost in the 3-2. Okay. Previously we saw 3-1. Now we are going for the 3-4. We see the mental flap. This is the mental foramen area. 3/5 is not very much ideal. So we will start from the 3-4. 3-4 will finish.
DCS should be in dense bone, so not in the cancellous bone. DCS should always be in dense bone.
Dense bone or buccal and cortical should be like
yes.
But if I put 3.6 here, it will be close.
Medullary, completely medullary soft bone, so it will
yes. 3.6 is not for this situation. Because the width is almost 4 mm. It may not be tight. But we can place a compression implant. So interforamina planning is over.
Yes.
Right? Now we will do the distal mandible. So it's very thin. Just distal to the mantle foramen. See the shape. Thin ridge. Already buccolingually thin. Luckily, foramen is visible. But here there is good cortical bonus there. Even if you do alveoplasty here, we can place a compression implant short. Okay. Or we can go like this. Lingual cortical. It won't break because there is a good bonus there. So we will try first the intramedullary, like this. This is okay. Okay, 10 mm or 8 mm implant will be fine. 3.5 into 8 will be fine. Okay, one more distal implant we need to place. See the anatomy here. Crystalline resorption is there. This is the myelite tissue, right? This is the myelite tissue. This is the deepest point. This is our target area. Either we can place implant like this or place a regular intramedullary. I prefer doing intramedullary because the bone here is good. Yes. It will get good stability. Why to complicate here? And good length also you can place still here. You will see the length. 10 mm we can place. 3.5 to 10 or 4 we can place.
Can you 8.5 about?
Yes. So left side it will be challenging because the roots are very much close to each other. Whenever the roots are close to each other, it becomes a very headache. If these roots are away from each other, the interdental bone will be present. We can use the socket. But once you remove this interdental bone, also will come. It will become a big socket. So we will see the anatomy. So this is the mesial root. Okay. Mostly this may be the foramen. So here we will see the myloid ridge. This is the myloid ridge. Okay, this is this deepest point. So the canal will be away from here, mostly here. So we can place the implant along it. If you see here, the root lingual, there is no bone lingual. Sorry, buccally. There is very little bone lingually. Buccolingually, it is a very tight space. So, by nature itself, patient, if the patient is having like this bone, right, or something like this bone, there will be a lot of bone here. But here, the lingual plate is very thin. So, these are the anatomic variations we should see. The entire root is occupying the socket. Imagine you are removing this tooth, there is nothing left in the socket. These are the challenges in 6. So see the interdental bone. No? It is good, but this interdental bone won't be there after extraction. Right? It's a thin septum. So 6 mesial distal thing will work out. So we are going for the between 6 and 7. Here it looks good. Right?
Yes.
Here it looks good. Buccolingually, there is some decent. Buccolingually, some decent bone is there. This is the myloid ridge. We can place the intramedullary. But where is the canal ridge? Yeah. You can see the canal here. That means mostly this will be the canal. So this is 4 into 9.5. We can place up to 10. Right? Because the canal is far away from here. So confidently we can place 4 into 10. So distal mandible we have placed only 1. So where to put the other one? Or we can leave it as such. We will try to place this interdental area. Here it looks good. Right? We can slant lingually close to the lingual plate and we can place a short implant. So the final plan is first premolar tilted, this first premolar, 2 lateral incisors, here 2 distal mandible, a very thin bone.